Thank you, Mr. Lucky, and welcome everybody. Uh, it's really a pleasure and an honor to be here, and I thank you for taking the time out uh, to come for this webinar. So I will be talking today about the introduction to the science of CBCT guided dental implantology, and we'll talk really about the basics and try to make you understand the concept and this treatment modality in total. And then Dr. Anurag will subsequently talk about uh, more details and show you a lot of clinical successes that we have with the modality. So this is where we are located in Rag Hospital. So the dental department is on the second floor of the eye care building, and you're very welcome to visit us anytime. And coming to the moot topic of dentistry per se, it's all about our teeth. And teeth, though quite neglected sometimes, are really a very, very important and integral part of our body. They play a huge role in our overall well-being. And as you know, digestion starts in the mouth. And unless we are able to masticate or chew our food well, the enzymes in the mouth and subsequent, the initial part of digestion does not take place. And it affects really a huge amount in our overall well-being. There's a lot of literature and, science to tell that if there is a lot of oral disease, it can have effect on our cardiac well-being, and especially in pregnant women as well, preterm births are seen. So it's very, very important that we take good care of our teeth, maintain very good stringent oral hygiene, so to make our health overall a holistic well-being in our lives. The other aspect, of course, is our speech. Our speech is very, very vital to us for communication. And then teeth play a very, very important role in speech. If you lose a tooth, you can notice for oneself that the speech gets altered. So a lot of fricatives, dentolabial fricatives and all. So plosives are there, which have totally depending on the position, shape, and size of our teeth. And of course, everybody wants to have a good smile. It's probably one of the most noticed features in our face. And smile and aesthetics go a long way. And we have a lot of patients coming in wanting smile makeovers. It makes a huge role, plays a huge role in our overall confidence, in our well-being. And to have a great smile is a great asset that we all want to have. And it's very much achievable with the so many different techniques that we have today. Now, the whole need for a dental implant has come about because of tooth loss. Unfortunately, there are a lot of problems which cause us to lose a tooth or many teeth. The primary cause is decay or caries. So as you can see in this picture where my cursor is, a lot of decay undermines the tooth structure and we end up just breaking the tooth, or there is decay in the root or the supporting part of the tooth, and there is no other option. The tooth becomes non-restorable and the only option is to extract the tooth. And then once after extraction is done, there's a huge need to replace that with the prosthesis. The other most common reason for losing a tooth is gum disease. So in case our oral hygiene is not good, as you can see in this picture where my cursor is, all these deposits or accretions on the tooth, they are calcified bacteria. And these feast on our oral, food products in the mouth, and then they produce toxins which cause loss of bone, the supporting bone of this tooth. And slowly the teeth become loose and sometimes not salvageable. And again, it's again a primary cause of tooth loss. Trauma, injuries, road traffic accidents, we have a bad fall, we break a tooth, sometimes the tooth gets avulsed or it comes off on itself in toto. And then some people genetically have missing teeth, congenitally missing teeth are also there. There are spaces where the tooth has not erupted. And so these all warrant replacement. And as we grow old, so a lot of literature that almost 60 to 70% of people will lose a single tooth when they reach the age of 60. So there is a huge need for replacement of teeth. And why it's important is because sometimes when younger people lose teeth, they think that, I'm chewing well, there is no problem, I can eat well. But as age catches up with us, the whole ecosystem of the mouth gets affected. The adjacent teeth start migrating, they tilt, and the whole bite pattern changes. And that's why it's very, very important to address tooth loss with a replacement as early as possible, because the bone also, which is there primarily to support the tooth, once the tooth is removed, the bone keeps shrinking. And once the bone has shrunk and lost, conventional implantology becomes difficult, though we have techniques of grafting the bone to add bone artificially to grow the bone. And Dr. Anurag will show you cases how, and even complex cases, how from very little bone we can recreate bone and then place an implant, which remains the best way to replace missing teeth. So you can see in these pictures, it starts from one tooth which is lost. The front teeth are very critical, and most people are anxious once they lose a tooth to get it replaced at the earliest. But back teeth also are equally important, though they are not seen, but they are the foundation for our chewing capability. So from one tooth missing to missing lot many teeth, and then we have techniques to replace so many teeth. And then the next level is the patient has lost all the teeth, and that is a completely edentulous situation, which generally is seen in elderly patients or in patients even at a younger age with very, very advanced gum disease, in which most of the teeth have been affected very badly that they have to be removed. So these are the three common situations where we need dental implants. From one tooth, many teeth, to all teeth. Implants can be used to have artificial teeth which are replaced best. Coming to the replacement. Now, there have been a lot of conventional dentistry is a very old science, and we've been replacing teeth many, many centuries from now. We've been doing that. And commonly, you've seen these partial dentures which are used. So these are removable. And so what the issue is, it's like they are not fixed. So they are resting on the gums of the tooth. And then they take support from the adjacent teeth. You can see these wire clasped, and we have different types of benches. Some are flexible, some are with a rigid metal framework, which are casted. And then these are the normal acrylic temporary partial dentures, which you would have seen commonly. Now, these are a good option, definitely, but they are not the best option because the chewing efficiency goes down. As you may know, if you're running on concrete or hard ground, you can run fast. But when you're running on sand, the foot depresses in the sand. So you don't get that support to run fast, right? Similarly, when the teeth have to chew, when the biting pressure comes, if it's a partial denture, it will submerge a little. And so that chewing efficiency is lost. So it's a good technique, but not the best one. The other technique is a fixed tooth supported bridge. This is one of the most common techniques. Until about 20-25 years back, it was the gold standard of teeth replacement. In this, as you can see in the picture, it's like you have a missing tooth. So we grind or shape the adjacent teeth to create supports, right? Like it's like a pillar across a river, or we create a bridge. So you have teeth which have been prepared to receive something like a crown, but these crowns have connectors which are connected to an artificial tooth. So this becomes like a span which is replacing this missing tooth, taking the support of these adjacent teeth. Now, it's very good technique. It's very efficient. It's fast to deliver within a week or even faster. We can do this. However, there are some inherent issues with this. The first issue is that tooth structure, as you may all be aware of. The enamel is the hardest structure there, right? Outermost. And inner layers are the most sensitive one, the dentine, and then we have the nerve containing structure called the pulp. Now, for a bridge to be done, we have to grind and shape this tooth structure by about a millimeter and a half in different areas of the tooth. And effectively, we are losing all the enamel of the tooth. And then, so we are kind of structurally weakening the tooth. And on top of that, we are putting load of more than the tooth that is supporting it. So 2 teeth are taking the load of 3 teeth. So it's weakened on one aspect and then overloaded on the other aspect. And then biologically also over a period of time. So it works great for about 10 years or so, 10 to 15 years. But then you end up having need for maybe a root canal in that tooth later on. Sometimes there are issues if hygiene is not maintained well. So yes, a very good technique, fast technique, but again, not the best technique. So the best technique as of now, okay, I'm talking about removal again, conventionally. When we have lost all the teeth, then you would have seen elderly patients using this called a complete denture. So this complete denture is resting on totally the gums of the tooth. As you saw in the picture, when totally all the teeth are lost, you have to have a replacement which is resting on the gums or the edentulous span. So this becomes a complete denture. As you can see, there is nothing holding it. It's all based on the fit of the denture. And it's all based on how well we can adapt, and the patient can adapt with the neuromuscular control, with the gums and cheeks, to control this fit of the denture. So chewing efficiency is about 10% of what we would have with fixed teeth. Yes, it's that low. Also, it over a period of time, as I told you, the bone will keep on shrinking after teeth have lost. So the fit of the denture from very good to begin with starts going down, 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 down over a period of time. And then you have to do revision. You need to reline the denture or make a new denture. Secondly, especially in the lower, the upper, the fitting is still better because you have a very large surface area. The palate is there. We cover the whole palate. And then, of course, it affects the speech initially, but then patients get used to it. But compared to the upper, the lower has very less surface area, plus the tongue in this region tends to lift the denture. So the lower dentures are generally much looser than the upper denture, and that's where the complaints of patients first come about. And that's why having at least 2 implants in the lower denture, which can help to hold the denture in place, is a great asset and becoming more or less the standard of care in such patients. So again, coming down to the options, a fixed bridge where teeth are present, where those teeth which are present are healthy enough to take that load, they are not mobile, or the span is not too large. Yes, fixed bridge is an option. If the span is too large, if there is bone loss also, then dentures are there, and if all teeth are lost, then we have to do dentures complete itself. But in all modalities here, there is a possibility of taking the help of dental implants. Now, dental implants sounds very fancy, but it's nothing. It's just like any other implant in the body. You have total knee implants, you have total hip implants, you have bone screws for trauma. These are all biomedical devices which are approved by regulatory agencies, backed by a lot of testing, experiments, scientific literature, and regulatory bodies, which are approved for human use. Very, very safe. And these dental implants are made of titanium and titanium alloys. These titanium alloys and pure titanium, is a very special material, because as you can see here in this picture, half the side is a tooth. So in a tooth, normally you have enamel on the part outside, dentine, and as I told you, the pulp, and then this part which is seen in the mouth is called the crown. But there is a part which is holding the tooth in the bone, which is called as the root. Now, this implant is like an artificial root, right? As how the root is there in the bone, our jaw bones, we are surgically, with a very minor procedure, placing these titanium screws inside our jawbone to act as an artificial root, to act as an artificial pillar, to act as a support for our artificial tooth or prosthesis, which is going to come on top. And there is an intermediary component also called as an abutment, right? Now, the beauty of these dental implants is that they have very special surface coatings. They are quite rough. They are special coatings, and the material titanium per se attracts bone cells to grow into them. So not only is it a mechanical screw which is engaging in the bone physically, but also biologically, the bone grows into this special surface over the implant, and that's why we call them as osseo-integrated. Osseous, you know, it refers to bone. Integration means it's a biological integration, and that's why this modality over a period of time is a very, very well-established clinical technique which has found great success. So now bone is a living tissue. It's not just hard calcified. It's not like nails. It's living with blood inside, and it keeps on remodeling. So the bone keeps on growing into the implant, and once that osseointegration happens, the implant can take all the load which a tooth generally takes. This biological process normally takes about 2.5 to 3 months. Yes. For the bone to grow in to the implant, this osseointegration takes about standard 2.5 to 3 months. However, we have techniques in areas like in the front teeth, or when we have more implants to support that, we can even put the teeth earlier than 2.5 to 3 months. But those are special situations, and that is called as immediate or early temporization or immediate loading. So you would have heard of concepts of tooth in a day. Yes, we can do that, but there are specific indications for that, specific conditions, and it's a patient to patient, region to region specific treatment plan that we can see only after seeing you clinically and judging the clinical situation whether it can be done or not. Standard protocol is 2.5 to 3 months. It's ready to receive the teeth on top. Now, this is how a single tooth implant. You saw this picture earlier. Patient has lost a tooth. As you can see, normally in the X-ray, there are roots of these teeth. And here in the missing area, we put in a titanium implant, which acts like an artificial root. This dark white shadow is what is called as the abutment. And on top of that is the crown. So to the untrained eye, it may be difficult to even know which is an artificial tooth. We can get such good results. Of course, dentists and trained people can make out if you look at closely, but on a professional 3 feet distance, nobody can even make out that there is an artificial tooth there. And beauty is we are not damaging any other teeth. We are not even touching the adjacent teeth. It's like as close to nature. So what it does is the forces when the patient bites even go into the bone. So this bone, as I told you, once the tooth is lost, the bone will get shrunk. But when the implant is put in, the bone is maintained because the normal stimulation of the forces are going inside deep into the bone. And that's why even the gums are maintained. So there is no gum shrinkage. Otherwise, when we lose bone, the gums will also shrink. And then there are spaces or dark triangles which are seen. But with an implant, we can ensure that it looks a very, very aesthetic white and pink. Gums are equally important. So we can ensure that all the biological structures are maintained as a natural tooth would have it with the help of a dental implant. Now, multiple teeth. So this is a little complex trauma situation. As I told you, the patient had a lot of trauma. There was a road traffic accident. You can see a lot of plating has been done. And he, unfortunately, young boy lost a lot of front teeth. So you can have a lot of teeth also supported by a lot of him. If you're replacing many teeth, depending on the situation, we can have less number of implants for more number of teeth. So you can have 2 implants for 3 teeth, even 4 teeth, depends on the situation, location in the mouth, quantity of bone, quality of bone. So a lot of clinical factors that you have to judge before we determine a treatment. That's why treatment plans are individual, customized. And that's why even the fee structure is not a standard fee, one fee for everything, because you have to judge clinically what the situation is, how many implants may be required, what kind of bridge or teeth on top will come, what kind of abutment will come. And that is what planning is all about, right? And for an overdenture, even as I told you, full dentures, otherwise they are loose, they can fall down. When patient talks, when the patient coughs, when the patient yawns, when the patient is opening mouth too wide, suddenly you find the denture falling down. And that becomes embarrassing for such patients. So when you have these attachments, so there are different ways of having implant overdentures. We have clips, we have attachments, we have ball abutments. So different techniques are there, but primarily it's something to hold on to the denture. So the patient can remove the denture with force, but it will automatically not fall down embarrassingly normally, normally how it happens in a conventional denture. And we also, the beauty of this is we need not cover the entire palate. So when normally, as I showed you in the earlier picture, the whole palate is covered. So many patients find that the taste is not great. They're not able to get natural feeling. Some people have gagging or vomiting reflex, which is very strong. And hence this becomes a very beneficial thing that we need not cover the entire palate also of the denture. And you can see we reinforce the denture with a metallic mesh or some sort of reinforcement. It's a strong denture, and then it is attached by attachment. So it does not, it's a semi-fixed kind of a prosthesis. As I told you, dentistry in general and implantology in specific is both biology and mechanics joined together. It's all about nuts and bolts as well as living tissue. So this is exemplified in the field of dental implantology. As I told you, there's a biologic process of osseointegration. Also, there is very, very important science of how well these components, it's all about nuts and screws and connections. So one component gets connected to another with a screw, with different types of connections. And there are many, many different implant systems in the world today. And we use a very standard system because as a patient, generally we are all moving around the world and follow-ups may be required. Some people relocate to different countries. So we use a very standard implant system which can be used, which is in use all across the world. So maintenance, follow-ups, which are important, can be done any location in the world. And the whole idea of having a success in implantology, and it's not about putting a surgical screw in the bone. Nobody wants just a screw inside the bone. It's all about having teeth. So implants are the foundation for a teeth. We are in the land of the Burj Khalifa. So how well the example is there. The foundation is for the world's tallest building. We need a very strong foundation. So the analogy is, as we have a building and we have to form a foundation, Implants, the building is the artificial teeth, and implants are the foundation for that artificial teeth, right? And how in architecture, the architects will first get a soil analysis. We do the bone density with the help of imaging only, bone density and even bone quantity, what kind of angulation will be there, right? How tall a building you want to make, that's how many teeth you want to replace, what is the design of the teeth, what kind of force factors are there. Is the patient very big, strong, chewing musculature, or very frail patient? What could be the loads which are going to be there in the teeth, what we expect them to be? And so how many number of implants, so how many pillars you would want, so how many number of implants you would want, what will be the specific location of those implants, angulation. So these are all part of what we do as the planning process. And then the surgical phase of the treatment of placing the implants, and then the prosthetic phase means making the teeth. So dentistry has evolved a long way from surgeon barbers to with very basic Stone Age techniques to casting metal. We had these drills, and now we're in the age of digital dentistry. Like anywhere else, any other world, technique like from smartphones, even now digital technologies have entered dentistry in a huge way, and we rely on that, on a lot of technologies to give good clinical success. So the first technology that we're using is CBCT, cone beam CT scan. So we all know medical CTs, you're lying down in a machine, very invasive, the radiation is quite high. And so this is a specific head and neck scan machine, which is tailor-made for dentistry, which is very low in radiation, as low as maybe, 50 microsieverts. 50 microsieverts is very low radiation. It's like about 6 days equivalent of radiation that we have normally. In a normal day, we would have 6 microsieverts in a day, and this is about 50. Oh, very safe, very easy. Don't have to get into the machine, no claustrophobia. Standing up, I'll show you a video of that. Done in 10-15 seconds, very quick technique, and it gives us huge amount of information. What is the quantity of bone? What is the density of bone? So it gives us huge amount of information. And the other is a very important technique of intraoral digital scan. So now gone are the days of physical impressions that you had to put and gagging, a lot of this, and I'll show you a video that we do. Then we rely on a lot of softwares for planning and CAD of the design. Then we do 3D printing for making these guides, the surgical guides which are used in the surgery. And then we do CNC milling for making the prosthesis or the crowns. So it's all digital in a big way. Conventionally, these are the 2D images that we take: panoramic X-ray, OPG, IPA, which we do in general dentistry normally every day on a day, and they still exist. However, we don't have enough information coming through it. So it's a 2D image of a 3D object. So it misses out on the depth or the thickness of the bone. So that is why we take cone beam CTs. This is how it's done in our department. We have machine, state-of-the-art machine right here. Very simple. The patient is standing up with some radiation protection, though the radiation dose is very less. And then the machine simply goes around the head for about 10 seconds and it's done. It's that quick. And then this is the intraoral scan in our department. It's called CEREC. We have a CEREC system in which we do single day crowns, single visit crowns as well in specific situations. And the same scanner is used to acquire the teeth data. So one CBCT gets the bone data and this gets the teeth data. So we are scanning the teeth, very comfortable for a patient. Again, a minute's job. So we do this, we take the scan. You can see in an optical scan, we get all the data of the teeth. So if there is a missing tooth, we know which tooth, ages, and how, all the teeth factors. So when we have to design teeth, we need this, right? And after this is the beauty. So we take this optical data of the teeth and we get the data of the bone and we join them together. This is the beauty of this technique, because earlier we used to do this separately and then we had to rely on our individual skills to combine the two. But now in the software, because now we do a retrospective planning, or we design the building first and then select the pillars. So digitally, of course. So we design what kind of crown will come, and then we decide what best support it should have for those crowns, depending on the bone which is available, right? So this is the beauty of this concept of guided surgery. And this is how we plan, just a snapshot. We design the teeth first. So we do a proper CAD designing of the teeth. What kind of shape of the tooth will be required? What is the height of the tooth? What bite pattern will be there? So all these factors are taken into consideration first before we even go for the bone measurements, right? Then we join these two data together. So this is merging or overlapping or superimposition of these two data sets. Once we have this superimposition, we can interchange the data between one another. So I can plan a guide on the model and that will fit on the bone, right? So this is how we superimpose or merge the two data sets. Once that is done, we have to look at some structures like a nerve, which is going down below in the lower jaw. We look it up, we identify that, we keep a safe distance for an implant from that. And then based on the crown, we choose the best position for the implant. And this is all in the planning stage before we even do the procedure. So we do a thorough planning. For that thing, you can see in different angles, we plan it, different angulations, we look at it, and then we design what is called as a surgical guide. Now, surgical guide is nothing but a template, which is a digital design and 3D printed template in acrylic, which is used during the surgery. So we translate our planning from the software into the surgical domain, and Dr. Anurag will talk about how the surgery is done, and you'll see so many cases there that this is the guide which we have designed is taken forward into the surgical table or while we are doing the procedure, because this is very important, because planning has always been done. It's not that it's a new thing. We always plan a procedure, but when we get down to doing it, there is a gap in the execution. So it depends on the skill of the surgeon, how well the planning can be translated during the procedure. So they can be, when we do freehand, there could be errors. All people try to the best of their skills, and there are a lot of factors in dentistry. The patient can close the mouth during the procedure, patient does not cooperate, moves, this and that. There's so many different factors that they can be a less than ideal outcome of an implant placement. And that becomes a challenge then for the teeth placement, because then it's not ideal position. And therefore, for a building to be successful, the pillar should be in the right position. Similarly, for a prosthesis or bridge or crown implant, should be in the right position to support that structure, right? So that's why execution of surgery is like a laparoscopic procedure. Some patients, we can, even if they're a good situation, we do not even make a cut. Not in all situations, some situations. So the beauty of guides is that it gives us accurate placement from planning to execution, and that's how. So this guide, which has been designed digitally, is printed in a 3D printer. You can see here it's being 3D printed, and then it is ready for surgery. And this is how it fits in the mouth. And then the drilling, which is done for placing the implant, is done through the guide. So whatever planning was done, it is replicated as close to ideal as possible. That's the beauty of this technique. Then once the integration of biology has happened, we need to design a top structure. It's called the abutment, this kind of a structure. So this is an interface between the crown and the implant. Now, these can be from the companies, you buy a ready-made shirt, it's like close to your size. But if you have a custom-made, custom-tailored shirt or a suit, that fits us best. Similarly, we have an option of using a stock abutment right from the company, different sizes, or we have the beauty now of using customized abutment, and they are all CAD/CAM made. So we like to prefer customized abutments, which gives us very good gum support. So how it comes out of the implant into the tooth, how it emerges, we can do a custom design and mill it to a great accuracy. And that is the beauty of using a custom CAD/CAM abutment, which will support ultimately the crown, right? So the basement is the pillar, which is the implant. The ground floor is the abutment, and the first floor is actually the crown, which we see in the mouth, the artificial crown, right? And then the CAD/CAM crown is again digitally made. So we have very accurate techniques of recording where the position of the implant is. Then we design it, then again CAD/CAM mill it. So it fits very beautifully over these implants. The fitting, as I told you, it's all about biology and mechanics, so nuts and bolts. So fitting is a very, very important part of it. So now in conclusion, I'll just tell you the basic process. You have to come in for a consultation. We do a clinical checkup. We look at your medical history. Are you a good candidate for it? Smokers, yes. Smoking does have a role to play in lesser success rates. Normally, success rate of an implant is more than 90% over 10 years. So that's very, very high. But then there are chances of surgical failures, and there are certain medical conditions or certain medications wherein we don't like to put dental implants or medical. So a clinical consultation is very, very important. We need to check how good fit you are. Generally, if one is fit for an extraction, one is fit for an implant as well. Then you need to get this cone beam CT, That's the standard of care. Unless we do that, planning an implant is really second guessing it. It's not ideal. So we need to get a CPC done. It's done in-house here. Then we do the planning and the intraoral scan as well. Then we do the planning. Then we do a review consultation. We formulate a plan and then discuss with you that this is the plan going to be like. This is how the timelines are going to be like. And once we have this plan, only then we can tell you a financial estimate as well. Because as I told you, these are all tailor-made, customized plans. It's not one size fits all. Once it's approved and we agree on this, and then we print the surgical guide, and then Dr. Anurag will do the surgical procedure, placing the implant. We wait in case standard care is there for about 1.5 to 3 months, and then we uncover the implant, and then I take over and make the crown and bridge or full arch prosthesis for making this, and there are procedures for that. Once we deliver it, we expect you to come for regular checkups because problems in implants don't cause pain. So regular follow-ups are very important. Oral hygiene is very important. Standard oral hygiene that you would normally take with teeth are required for an implant. And then follow-ups are important. Once in a year, once in 6 months, depending on the situation, we advise follow-ups, and then so that we can maintain it. With this, I conclude my part of the presentation, and I request Dr. Anurag to take over and continue with the surgical aspect of this technique. Dr. Anurag? Any questions we can address at the end of this presentation?
Abhinav, is my screen visible?
Yes, doctor.
Yes, Anurag. Yes.
Hi, good morning, everyone. Accept greetings from Dental Department, RAC Hospital. So, Dr. Abhinav already went through how the planning is done and what all is the prerequisite for getting an implant done. I'll just quickly go through the little bit of planning for making it a little more simplified for the patient. So that's the hospital that we practice, and we welcome all the patients who are in need for dental implants to this facility. I have a slight disclaimer to make that we have already taken consent from all the patients that whose pictures and videos will be shown in the presentation, and all the work shown here is my original work, and we have not been borrowed or copied from any other source. And I don't have any financial obligations towards the companies or any of the implant companies that we will be showing during the presentation. I acknowledge that few slides in the presentation have been taken from Katara Dental Private Limited, who are our lab partners, and Dr. Abhinav Sood, who is my prosthodontic colleague in the same hospital for planning and fabrication of surgical guides. So in Branemark era, so Professor Branemark was the one who researched about dental implants, and he's the one who coined the term osseointegration. He found out that titanium has these properties of where the bone cells grow over it, and over a period of time, the titanium gets incorporated in the bone and is ready for any kind of loading purpose. So when this so during Branemark era, once they found out that implants can be placed in the bone, now during that time, not enough. Hello, sorry. So at that time, not enough emphasis was laid on the prosthesis part. So people were placing implants in the available bone. But now we realize, as Dr. Abhinav also discussed, that we need to have the pillars or the implant at the right places for the prosthodontic colleague to be able to place the teeth in the right position. So we call it prosthetic, or we call it reverse planning. So we plan the ideal tooth or teeth or the prosthesis first, and then we look for the ideal bone position and place implants. So what basically CT scan guide does is give us a lot of information about the quality of bone and the quantity of bone which is available for the ideal tooth position. And there are no surprise element when we are doing surgery. So we know everything before we plan the surgery. If there is deficiency of bone or soft tissue in the same area, we know it beforehand, and we can therefore modify our treatment plan. Or maybe if we have to do grafting, if we have to do soft tissue grafting or bone augmentation, bone grafting, all those things are known before we propose the treatment and before we execute the treatment. So there is no surprise element during the surgery. So as I told you, like initially, or this is the result of poor planning and poor execution. Now the implants have been placed These are the models. The implants have been placed in the bone, but there is no way that any lab or any prosthodontist will be able to put teeth in ideal position in this scenario. So we want to avoid all these kind of things. So since implantology has grown over the last 30-40 years, so that is why computer guided implant surgery placements are the choice as of now. So the unforeseen problems in implantology are that when you don't give enough importance to prosthetic plan, when you don't give enough importance to anatomic considerations, which are our limiting landmarks like inferior alveolar nerve in the lower jaw, nasal floor or maxillary sinus in the upper jaw. So we do see a lot of complications by clinicians who are not adequately trained or who don't give enough importance to the planning aspect. So the complications that we normally see in any implant cases are surgical complications, which happen early. It can be during surgery or it can be immediately after few days to few weeks of surgery. Or we have prosthetic complications. So prosthetic complications that if you have placed implants in wrong angulation, the wrong positions, then it's not possible to put crown there. So the overall result is negative. Whether you have a surgical complication, you have a prosthetic complication, you are losing patients' confidence in you. So the most common complication, as I told you, is malpositioning error. That means you have positioned or you have angled the implant in a wrong position. So when we are doing CBCT planning, when we are doing a computer-guided surgery planning, we are avoiding all these completely. Now you see this is a 2D image. It's a panoramic image where you can see two implants. So this patient was referred to me because this patient kept losing a couple of implants. So the patient was only having this 2D image. And then ultimately, clinically, I knew that something is not right. So we asked for a 3D or a CBCT scan image. Now you see two implants are placed in the bone. They might be looking okay on the X-ray, but you see how they look on the CT scan. This implant is, if you can see my cursor, this implant is completely outside the bony window. So this clinician has gone wrong in the planning and he has executed also wrong because he was not working with enough information. And that is what we want to avoid at this stage. This is again an axial image of the same patient, of the same scan. You see the available bone highlighted in the blue, and then the implant is completely outside the bony window. Again, you can see two implants may be in decent position. The third implant is in the palate. There is no way that any prosthodontist will be able to make a bridge on this situation. So we want to avoid these kind of situations. Again, one more model, see where the implants are. There's no way that you can angulate and you can correct this prosthetically. So we don't want implants. So patients, we see a lot of patients coming in. The only thing that they want to know is how much will it cost. Costing is a separate, altogether a different thing. What we need to do is for any procedure, it has to be a customized, because as Dr. Abhinav also said, all these cases are customized cases. So we need customized solutions. We cannot have one solution which fits all. So how do we plan now? We do reverse planning. So we plan the position of the missing tooth or teeth first. We plan the prosthesis first. And how is it planned? It is planned in relationship with the adjacent teeth, so that it is not looking awkward in your mouth, and it is meeting in the perfect manner to the opposing dentition. That is how you plan. So these are the prerequisites for any successful outcome procedure. You have to do careful planning. You need to know the relevant anatomy of the area where you're going to operate. You need to be accurate in your plan. Precision will be there if you're doing a CT scan planning. And you have to have some sound clinical judgment before we propose the plan to the treatment. Now, the issues with non-guided or freehand placements, we were all initially doing freehand placement when we did not have this facility to do CBCTs and do surgical guides and all those things. So we were relying only on our hand-eye coordination. We were relying only on the angulation of adjacent teeth, which sometimes is not ideal, and maybe an assistant or a mentor guiding you in your directions. So you can go wrong in any of these aspects. Initially, this is how the glides were planned. We used to have radiographic marker in the denture. The patient will go for a scan again. So again, double radiation. And then looking at those radiographic markers, we look for appropriate places in the bone where the bone is available, and then guides were done. Now everything is done mostly in one single step. Now, there were flaws in this conventional guides. There was a leeway in the drilling trajectory. That means through one hole you can go through the one hole placement, you can have different trajectories. You can go wrong, you can go, you can place, you can guide your drills in different directions. Then the other problem was there was nothing which was stopping you. What is the depth control? There was no depth control here. And it was only providing information about the position. It was not providing enough information about the size, about the diameter of the implant, the length of the implant, and not too many anatomical considerations were taken in account for. And then there could be operator related variables. If the operator's hand is not so stable, you can have malpositioning errors. You can have drill going into different angulations. What if the patient's moves or cough during when you're doing actually drilling? Assistant's feedback, if your assistant is not able to tell you the right feedback, it will not be able to give you a right information about at what angulation are you drilling, you can go wrong. And then, as I told you, because there is no depth control, there are chances that you can violate next anatomical structures. So anatomical variations like deficient bone volume, bony undercuts, adjacent root approximation if your teeth are tilted, or proximity to inferior alveolar nerve or maxillary sinus, these things are not taken into consideration if you're going traditional implantology. So yes, we have a better solution which is more accurate, more predictable, safe, minimally invasive, and then you can return to function quite early. And then there are definite prosthetic advantages, like you can have pre-formed temporary teeth which can be made ready before the actual procedure. You can have Dr. Abhinav showed you how custom CAD/CAM abutments can be made, and we can restore the function aesthetics in a much better way. So this is a typical guide, how a guide looks like. It's a 3D printed guide, and you can see some metallic sleeves inside. So when you're doing a guided surgery, the advantage is that first of all, you will have depth control because you cannot go beyond this. There will be a depth control. So the drill guide will not go beyond a particular limit. And then your angulation also will be accurate because then you cannot change the angulation during the procedure. So how computer-guided surgery is done? We have a planning software. Dr. Abhinav already showed you. We have the CT data. So once we see a patient, we do an intraoral scan. We have a CT data. Then we use a software to merge everything together. And then a 3D printed guide is made. And all the structures, relevant anatomy is taken into consideration. So we exactly know what is the right size of diameter and length that we're going to use. And there are so many checkpoints in the software which are incorporated that the scope of error becomes very less, and then we have limited, very less complications. The advantages are that there is less stress to the operator, less stress to the patient also. The operating time is very less because you already know your plan. There is no such surgical surprises, and increase in patient's acceptance and short and better recovery of time. Now, for example, I'm just showing you some clinical situation. Now we have the scan model of the patient. You can see missing premolar teeth on both sides. This information is shared say for here, Dr. Abhinav does the planning. So he has this information. He will do the CT scan. We will have the 3D model also of the patient. And that's a CBCT scan image. Opposing dentation, we scan the opposing dentation. So we have all the information, how the teeth are going to meet in the opposing dentation. These teeth are virtually created using the software, using the opposing dentation information. You can see both the premolars have been virtually created here. Then we have the CT data. Now this is incorporated together. They are merged together. This is how the merging is done by using the software. And this is the ideal position of the implant in respect to the teeth which are going to be replaced. And this is how this is just the planning part. This is how it is planned. Then we have the guide, and the same guide is printed. Now this is virtual. This is the real guide. So what do? We just give local anesthesia to the patient, try the guide, put the guide, and just go through our drill with the drill, because we already know the size of the drill, the length of the drill. You can see that it will not allow us to go beyond. It will not allow us to change the angulation. So anatomy is taken into consideration. We are not going to go too close to the adjacent teeth. We are not going to perforate the sinus, because all this checklist is already incorporated into the treatment plan. So you see within few minutes you have both the implants in place, ideal location, ideal placements, and patient can have future teeth in more or less an ideal situation. Again, on the left side, right side already done on left side. You can do multiple sittings, multiple implants at the same time because this is a minimally invasive procedure. Now, this is the OPG of the same patient with 4 implants, and the patient is wearing her temporary teeth over the implants. Another case, this we can do CT guided procedures in cases when we are removing the teeth also in the same sitting. So those are called immediate extraction implant. You remove the teeth and you place an implant immediately at the same time. And so all this planning information is already sent to the planner. For example, Dr. Abhinav already knows that these teeth have to be removed, and then an implant has to go in that place. So he will virtually or digitally subtract that tooth from that area and then plan accordingly. These are implants done before by somebody else. And then this is a clinical situation. You can see certain left side teeth are missing. This canine was to be removed. This is how, again, the planning part, you know that you have to take into consideration nasal floor here particularly in the canine area, and then proximity to the adjacent implant, which was already there in place. This is the planning for the left side. So left side, you can see we know that we are going to bypass the sinus. So the implants are positioned in such a way that we are bypassing the sinus. Again, we fit the extraction was done. The guide was tried in the patient's mouth, and you can just put that, take the appropriate drill and sequentially drill and place the implant. So it's not difficult. Again, the left side is being done. Left side is done in a couple of minutes, and the patient is back home in a couple of minutes without any swelling, without any soreness, early return to function. You can even do immediate temporaries if that's a part of your plan. So that's how it is done. Same patient, you can see healing abutment already placed. The canine socket was closed. There is no bleeding. So since we have not raised a flap, minimum chances of any kind of swelling or post-operative soreness. Again, a different situation, left lower jaw, multiple teeth missing. Again, we have the CT data, we have the digital data, and we merge them together. That's a guide. You can see 3 implant positions in the guide. The guide is fitting well in the mouth. Just give local anesthesia. Go with your sequential drills, place the implant. You can see the implants in the mouth. And absolutely, patient acceptance is very, very high when you're doing such procedures. Another case, patient reported with a couple of missing teeth in the front teeth. Now here, I did some bone grafting 6 months back, and then patient underwent a scan again, and then again digital model was made. This is patient's actual picture. You can see right side couple of teeth are missing. This is the scan of the patient's dentition. Virtual placement of implants has been done here. You can see this is the CT data of the same patient. You can see the implant placements virtually created here. And then you just put the guide in the patient's mouth and go with your sequential drilling. And you can place the implants. Now this was planned to have immediate temporary. So you can see temporary abutment in place. And within half an hour, 45 minutes, the patient goes back with temporary teeth in the mouth. So all these things are planned, and all these things can be executed because we know what we are doing before we begin with. That's the same patient's X-ray. Another situation, multiple missing teeth, multiple decayed teeth which required extractions. Now this particular patient already had a low or a highly pneumatized sinus, so it was planned to do a sinus graft at the same time. But the beauty of doing a computer-guided surgery procedure is that you can combine a lot of surgical steps together. So this patient, and this is the lower jaw. So this patient, this is the plan for the lower jaw. Again, couple of teeth to be removed, couple of implants to be placed in the lower jaw. This is the guide. You place the implant in the patient's mouth and go with your sequential drills and place the implant. Again, now here, if you can see, the certain implants are a little away from the bone, not completely in the bony window. So this also you can discuss with the patient that, this is the ideal position, but you don't have enough bone in this situation. So we will need to graft this area. Rather than telling the patient on the chair after doing the surgery that we need to modify the plan, all this information we already have. So the patient already knows that this is an additional step that will be done during the surgery. So no surprise element. So you can see the implants have been placed, and then you can see some bone graft membrane to cover on top of it. And then, so this is the implant. You can see some extra bone graft membrane covering the implant. This is the lower jaw. And then if you see in the if you see on the in the upper jaw, the sinuses are pneumatized. We hardly have enough bone to place an implant without doing an adjuvant procedure. This is the upper jaw. These are again virtually created places where we have to place implant. And then we already know that we don't have enough bone. We'll have to do a sinus graft in this situation. You can see the most of the implant is in the sinus, and there is not enough bone. So all this is very easy. When you have a definitive plan, you can explain to the patient understands that there is an anatomical issue, there is some bone deficiency issue. So so it's easy for us to be able to make the patient understand that why we are doing adjuvant procedures, because the patient does not have bone. So now my implant positions are fixed because I can't change my implant position, because the teeth position will be in the same situation, in the same place. We can't change the teeth position. So once this is done, then I know that, these are my future implant positions. I will do my surgery. So that's a window which has been made in the maxillary sinus. So I'm doing a sinus lift, direct sinus lift at the same time. And you can see some membrane tags. The bone graft has already gone in. And you can also see that I've already placed my implants also. Similar situation on the left side. So same time, we do a sinus graft. We place the implant also at the same time. We do bone grafting. Everything is done in one step. So these are obviously some advanced procedures. But yes, it is possible to do it in certain situations. And that's the same patient's X-ray. You can see implants. You can see small bone tags, which are used to stabilize the membrane. And you can see bone graft in the sinus, which has been placed to augment bone in that area. So all these things can be done in a single stage if patient's medical condition allows. And the advantage is that now my implants are in ideal position. My sinus graft is done. And future, my prosthodontist colleague can take over and can restore these teeth easily. Again, a completely edentulous situation where you can see the patient is wearing an upper denture. Couple of teeth are there in the upper denture. Lower teeth are missing. Some of the lower teeth are supra-erupted. We call it as a combination syndrome. So once you remove the partial denture, this is how the patient's residual teeth are. So planned, remove, all the extractions were done. You have a guide. You can see this is a special kind of guide where some anchor pins are used, because there are no teeth to stabilize the guide. So we use anchor pins. And after the anchor pins are done, this is how we do all on four. All the implants you can see are in good sound bone. You put multi-unit abutment, you take an X-ray, and then the patient is ready to be taken over by a prosthodontic colleague to be able to do a immediate loading and immediate denture on this kind of situations. I'm just showing you different scenarios. Again, this girl was a dentinal dysplasia case. So you can see already bone grafting was done. You can see those membrane tags in the X-ray. So sometimes you don't have to even go and remove the tags, because if they're not coming in your way of osteotomy, you can leave them behind. Again, CT was done, virtual planning was done. Okay, this patient had this kind of history. So she denied any autogenous bone graft. And then obviously doing autogenous block grafts or different bone grafting procedures, it needs to additional cost and multiple surgeries and time. So we did a CT scan, virtually planned her teeth, and then looked at appropriate places. So we will see my implants at different angles. This is all planned because the teeth are planned first. So we know where the teeth position will be, and appropriately then we look for without being done a lot of extensive surgical procedures, we can plan our implants. And then you can have the multi-unit abutments. You can place the multi-unit abutments and then go ahead and plan your implants. And then we went ahead. If you can see the lower jaw, the patient had a canine which is in a sleeping position. So even this was done successfully after doing a CT guided surgery. This was the lower jaw. So canine was removed. This is the guide, and this is the implants. Now these implants are in correct position because we have already planned our teeth position first, and then this patient is ready to be taken over by the restorative dentist to to manage the bridge or now it's just a small video how a CT guided procedure is done. You can see already the guide is in place. You just go with your sequential drilling. You see that this sleeve here will not allow us to go beyond a particular depth. And then you go ahead and you do drilling for the adjacent teeth. Now here I planned for an indirect sinus slit. So you see I've taken a shorter drill, which will be 1 millimeter short of the sinus. So once you do this is not a fully guided procedure, but yes, this will give you my pilot holes, because then we had a little different plan. I had to expand bone and do a sinus indirect sinus lift. So this is not a fully guided procedure, but yes, this is more or less a guided procedure. Now I'm expanding my bone using special drills, because this was a plan. Then I only wanted my implant location, and rest I am doing freehand. Now, if you see on the second osteotomy, I will not go full depth. I am just going and controlling my depth because I'm very close to the sinus floor. So that information I get by the tactile sensation. And then once you do this, once you've lifted the sinus, once you've done your expansion, that's how an implant looks like. And that's how an implant is placed in the osteotomy site, which has been prepared using special drills to condense bone into that area. That's my first implant going in. And you can see the patient is comfortable under local anesthesia. It's a 10-minute procedure. It does not even take 10 minutes to do it. That's the first implant going in. And that's the second implant going in. So from starting to begin, it's not even a 10-minute procedure because everything is planned. No surprise element. That's the first implant. That's the second implant. And then you just put a couple of stitches and you're done. So in conclusion, I would say that computer-guided surgery is the future of implant dentistry, and sooner one incorporates into their practice, the better it is, because the advantages are manifold with a very small increase in cost of the treatment. So just a request to all the participants who are viewing this webinar that each situation is custom made. So if you have a patient or if you are looking for dental implants, please come to us and let us propose as a treatment, and then you decide. Thank you very much. Any questions, we can take it from now.
Thank you, Doctor. Thank you. It's a wonderful presentation, actually. So, dear participants, you can unmute yourself and ask your questions directly to Doctor. So, if anybody has a technical issue, unmuting the mic, you can just text in the chat. Doctor, we got a question. If you lost a tooth for a long time, is it still fine to get a dental implant?
Yes. So if a tooth has been lost for a very, very long time, so we do expect some bone disuse atrophy. So we will, especially if the patient has been wearing a partial denture or something like that, which causes a little pressure on that bone. Otherwise, we can always do a CBCT to have information in all three aspects. And then even if the bone is deficient, there are ways to place an implant and augment that bone. There is it's a possibility.
Thank you, Doctor. There's one more. How long the dental implant lasts?
Okay, so
is
dental
there
implants,
any expiry date?
No, so dental implants are not like your hip replacement joints or any other replacement joints where the orthopedic colleagues say that we might have to, because they wear out after a certain time. But with dental implants, there is no such thing that we have to replace it. Unless and until implant fails because of any other reasons, there is no need to replace it. If you are coming for your periodic checkup, everything is going fine medically with you, there is no new changes in the bone in terms of your medical condition, we don't have to replace it.
So the question is it a lifetime?
Sorry?
The question again is it a lifetime?
Yeah, so implants are meant to serve, I will not say that it has long life. You know, nothing is lifelong, but it has a long life. So when I'm telling you is that we don't have to replace implants unless and until there is some issue which has developed because of overload or whatever condition that we have to replace an implant. Otherwise, it's not warranted to be replaced, unlike your other implants in the body, like your joint replacement implants.
If I may add, the prostheses are also being there. So there is a regular wear and tear as you would have on your teeth with time and age. So over the years, you may need a revision in the prosthesis or the crown. There may be some chipping, there may be some screw loosening. So definitely that is why we want to emphasize, like, you buy a supercar, even that needs maintenance. You buy any mechanical component that requires maintenance, and this is mechanical as well as biological. So regular follow-ups and checkups we cannot overemphasize the need for that. It does not mean that you have to come to the dental clinic every week. It's all about once in 6 months, once yearly, and that is very, very critical. And oral hygiene is very important. So we have surgical success and then we have prosthetic success, but then you want to use your teeth lifetime. For lifelong, we have to maintain them. So if you want to use the implants lifelong, you have to maintain them, and that means hygiene and checkups.
Mr. Samir is asking, I need 2 implants. I need to know how many days it takes overall. So, Mr. Samir, as you know that implant is a 2-step procedure unless and until you are looking for a front tooth replacement where we can give you a temporary tooth immediately. What you need to do is you need to come one visit for diagnosis. You know, for that we need to do your intraoral scan and a CBCT scan. So once we have the scan and everything ready, then we can propose your plan. You can choose your date of procedure. Procedure will not take more than 20-30 minutes. Once that is done, then we need, if it's a back tooth, so usually we don't put the crown on the back tooth immediately. So you need to wait for at least 8 to 12 weeks for the osseointegration to take place. And then after that, there is a stage 2, which is a 5-minute procedure where we just uncover the implant using soft tissue diode laser. And then the prosthodontic colleague here, Dr. Abhinav, is going to take again scanning or impressions and then deliver you the crown. So overall, if you say from day 1 to the time that you get crown, 3 to 4 months. But that does not mean that you have to come every now and then. Once the implant is placed, we will see you directly after maybe 8 weeks or so, 8 weeks to 12 weeks. So dental implant is simpler than tooth extraction. So the instructions are similar when we do an extraction. It's a simpler, same kind of instruction. That same day, because a procedure has been done, mouth will have a little soreness. So you will be on antibiotic and some little pain medication and all. There is no such restrictions. But yes, same day, nothing very hard, hot, spicy to be only for 24 hours. You can have regular food, not a problem.
And if I would add, in case we are doing an immediate loading or immediate temporization, that means in certain specific situations, we give you fixed teeth on the implants right after the surgery or within 48 hours, like a full arch. Then there are dietary restrictions till the time it is healing. So then you have to be on soft diet. You can't have very hard diet because we want to limit the force on healing implants. But once they are healed and once everything is made, the bridges and the crowns are made as final, you can have what you want. However, if natural teeth can break, even crowns can break. So you have to be judicious about hair. That's about it.
So no. So it will not be detected in the airport. There are millions of implants placed world over in a year annually. So nothing will be detected. That's not a problem. Okay, you said you have a sinus. So it depends, what
Sinus.
kind of sinusitis you have. If it's a chronic sinusitis, so it all again depends whether we are actually doing a sinus procedure or you need a sinus procedure or no. So if a patient is having chronic sinusitis, so we usually avoid doing a direct sinus procedure. There are short implants available for that situation. So again, we need some more data before we can plan, before we can propose a plan. So short implants, you can avoid the sinus completely, and you can still have an implant and you can still have a tooth.
Along with the metal detectors, another frequent question asked is, can I get an MRI after dental implants?
Yeah,
So
it's absolutely safe, not a problem.
So these are non-ferromagnetic materials and anything fixed as well. So it's fixed to the bone. So there is no issue at all with any MRI, God forbid if you need one.
Any other question, please?
Can we give 2-3 minutes? Let them.
Yeah, sure.
Sure.
All right, doctor. Thank you. Then we will end this. I think
Are we
there are no more
concluding?
questions.
Are we concluding now?
Yes, doctor.
Thank you. Thank you, everyone.
Thank you.
Thank you, Abhinav.
Thanks.
Thank you so much.
Thanks for all the participants again.